Suka? Sini? Sini? So remember, we touched it first at the sternum. When you're assessing at each dermatom level, ask him whether he feels it the same as here. And later, when you go to the other extremity, ask him to compare right and left. Understand? To see whether or not it's the same at both sides. And do you all know what is glove and stocking distribution of sensory? Okay, it was discussed already. So should there be some sensory loss at the distal part, where you need to find at what level it occurs, you move in 5 centimeter increments, and you find that level at which sensation is lost. The level at which sensation is lost, let's say it's here, above here should be a level of hyperesthesia as well. And this is also something you need to detect. Okay? So, you've assessed pain.
Can you repeat the last sentence?
Let's say there's loss of sensation. Progress. Under a certain, let's say under here there is loss of sensation. But right above it, there will be a level of hyperesthesia. This one also you need to determine what is the level. Okay? So, you do pain, dull touch, hot and cold, all according to the dermatome distribution. For hot and cold, according to the books and all that, you should have special test tubes, and one is for hot, one is for cold. But if not, a rough substitute would be this part cold, the rubber part hot, warm. Okay, so if you're in a pinch, you can use that as well. At the extremities, if necessary, you can do 2-point discrimination. You find out what is the maximum distance a patient can feel that tool as 2 separate points. And then for proprioception, what finger should we assess proprioception?
The most distal.
The most?
Distal joint.
Most distal joint of which finger?
Third.
Actually, it should be the little finger, because proprioception is lost from the little finger first. Then only you go to the other. This one is in Chinese. And yes, you need to assess at the distal joint. And remember, you need to hold it at the side of the fingers, because if you do it like this, you can stimulate the pressure receptors, and therefore your findings won't be accurate. So, kepit at the tepi. And first, the patient's eyes should be open and look. So, I think you want to sit up. Thank you. So, cek. Kalau macam ni, maknanya saya gerakkan dari ke atas. Kalau macam ni, saya gerakkan ke bawah. So the patient looks, and then you explain which one is up, which one is down. Then only we ask him to close his eyes, and we repeat this movement randomly, and ask him to tell us. Okay, cek, tutup mata, lepas tu saya gerakkan, and then kita cakap di atas ke bawah. Ini ya. Okay, proprioception is fine. And repeat that for the other side as well. Lastly, vibration. Vibration, you need to assess. Some say you should stick to the bony prominences. Some say it's just as good over soft tissues. But as a rule, we still do it over the bony prominences. So you take the tuning fork, hit it, and then you put it at the distal interphalangeal joint. If distally, you can already, the patient already feels that vibration, you don't need to assess further. If you need to assess further, then the next point will be over the ulnar prominence, not over the olecranon. Last point is over the shoulder joint. And when you put the tuning fork, ask the patient, number 1, can he feel it vibrating? Number 2, while it's there vibrating, you suddenly go and stop it. The patient should be able to tell the exact moment when you stop that tuning fork. That means the exact moment when the vibration is stopped. Okay? So that was the sensory examination of the upper extremities. If necessary, you assess the dermatomes over the chest, over the abdomen, and one more thing you need to assess over the abdomen is the superficial reflexes, the abdominal reflexes. That one, you assess the 4 abdominal quadrants by lightly stroking the skin towards the umbilical cord. 1, 2, 3, 4. You should see a slight contraction of the abdominal muscles. Can be absent in normal people, can be absent in obese people, but again, if it's present with other clinical signs, it indicates an upper motor neuron lesion. Level of the epigastrium is TH6 to TH9. Here, TH9 to TH11. Lastly, TH11 to lumbar 1. Okay, so this again will help you to determine the level of lesion. For the lower extremities, again, we start off by testing pain sensation according to the dermatome, dull touch, temperature, vibration. The most distal point will be at the metatarsal phalangeal joint on the side here. If you palpate on your own foot, the most prominent part will be there. Next point, malleolus. Next point, patella. Highest point is the anterior superior iliac spine. And the superficial reflexes that you need to know are the cremaster reflex. You stroke the inner part of the thigh, and then there should be contraction of the cremaster muscle. That one is L1, L2. And also the anal sphincter reflex. This one is very important, especially if you want to distinguish between caudal equina lesions or intrinsic spinal cord lesions. Because if you look at the dermatome distribution of the lower extremities, you will see that S3, S4, and S5 are all concentrated around the gluteus region. But the nerve segment which regulates the sphincter reflex is S2. So if you assess the dermatome and see S3, S4, S5 got S3, S4, and S5 are gone, you want to determine is S2 involved or not. So you take that toothpick and you touch the perianal skin and see if the anal sphincter contracts. If it contracts, S2 is preserved. If it doesn't contract, S2 is also involved in the lesion. Okay? Okay. Basically, that's about it. Just go back home and revise the dermatome distribution, muscle groups, and the muscle innervations. And also, let's say a peripheral nerve is involved. What would be the picture involved for that peripheral nerve? Oh, and actually, this one I see some people do it and some people don't do it. That's why I kept it for last. But I personally think it's good practice to do it lah. That before you start off the neurological examination, you should assess active movement of the patient first. Like, first of all, can he move on his own? And for upper extremities, it will be just those who do it. What I see that they do is they ask the patient, can you lift your hand as high as possible? The other hand. And same for the lower extremities, to lift the leg as high as possible. Jangan terlalu. Okay. And I believe that's it. Any of the seniors want to add anything?
Oh, for pain you use the media, and then for touch you already use the music.
For touch, you use the cotton. Yeah, yeah, the cotton. Something like the corneal reflex one. You use that and you touch. Oh, the finger. Yeah. Thank you. I missed out that one. You ask the patient to flex his fingers. Then you cover with your own fingers, and you use the tendon hammer and strike. You should feel slight flexion of the fingers.
This one is
or the finger reflex also, I think.
oh, this one is Rosalind's, right? Yeah, I mean you strike the other one is Hoffman test. Where the hand like this, then you flip like this.
Oh.
Then
That one, that you get
yeah. So okay, I will just add on what is related to it. So Hoffman reflex, ask the patient, relax your hand. Then take this part of the distal triangle joint, you try to flick it like this. And what you should observe? Don't observe the base, observe the tongue. See whether there is any pincer movement like this or not. If this present, this one means Hoffman positive, indicate upper motor neuron lesion. And okay, apa boleh balik? Mesti balik. Okay, so in addition to the tone just now, what other thing? This one is not a standard one, but there's some additional that we can do. Example, checking for the tone, you can do so-called rolling test.